Imagine for a second that you are holding someone's life in your hands. Like, literally.
Yeah, a terrifying thought for most of us.
Right. You are a highly trained medical professional. You're staring at a patient who is in pain, and you know exactly what they need to get better.
You have the skills, you have the knowledge, the medication is right there.
Exactly. But here's the catch. If you make the right moral choice, the choice that helps this person sitting right in front of you, you might actually get fired.
Or sued for hundreds of thousands of dollars.
Yeah, or in some incredibly complex scenarios, you might literally be sent to federal prison for up to 10 years.
It sounds like an exaggeration, right? Or maybe some sort of dystopian legal thriller. But it is the absolute, unvarnished reality for healthcare professionals every single day.
It's wild to think about.
It really is. The choices they make are almost never binary, and the stakes quite literally could not be higher. Every time a provider interacts with a patient, they're basically walking into a minefield of conflicting obligations.
Welcome to the Deep Dive. Today, our mission is to navigate this incredibly complex labyrinth of modern healthcare.
It's quite a maze.
It really is. We are pulling from a fascinating stack of source materials today, primarily texts by Carolyn Buppert and K.T. Waxman, which they tackle the legal, ethical, and policy issues that completely define how care is delivered.
To set the stage for you, we are exploring how advanced practice nurses and other healthcare professionals balance these massive systems.
Right, the macro level stuff.
Exactly, the infinitely complex financial and legal wellness of modern healthcare systems. And they have to balance that with the micro, right? The intimate ethical duty of protecting vulnerable patients.
It's like a constant, exhausting tightrope walk. You've got national budgets, insurance networks, federal statutes on one side.
And on the other, the person shivering in a hospital gown, relying entirely on your judgment.
Right. And the foundational core conflict of this entire deep dive comes down to the friction between ethics and law.
Which is a violent friction in medicine.
Yeah. Now, we all know ethics deals with what is good or right, and the law is the set of rules we have to follow. But ethics is full of gray areas. You know, it asks, what ought we do for this human being?
While the law, on the other hand, consists of rules created by legislatures and courts that attempt to be black and white.
It dictates what we were expected to do under threat of penalty.
Exactly. And honestly, the law often entirely fails to capture the nuance of human suffering.
I mean, that friction is exactly where medical professionals live. And to survive this labyrinth, they can't just rely on a personal moral compass.
Right. You don't just walk into a hospital and start winging it based on your own internal vibe of what's right.
Yeah, that would be a disaster. There is a deep historical framework at play here.
There is. If we trace the history of nursing ethics specifically, we see an evolution from strict obedience to complex autonomy.
Okay, let's unpack this because it starts back in 1893, right?
Yeah, 1893 with the Florence Nightingale Pledge, which was established by a committee headed by Leicester Greder.
Right, and back then, it was heavily focused on very rigid rules of conduct. An early emphasis was just basic patient safety.
Specifically promising not to take or knowingly administer any harmful drugs.
It was essentially the nursing equivalent of the Hippocratic Oath mandate to do no harm.
But things have evolved massively since 1893. We aren't just promising not to poison people anymore.
Far from it, yeah. The modern compass is the American Nurses Association Code of Ethics.
Adopted in 1950, originally.
Right, and it's been heavily updated, most notably in 2015, which the ANA actually declared the Year of Ethics.
That update was pivotal, honestly, because it incorporated our modern societal perspectives.
It moved far beyond just the bedside, right?
Exactly. It addressed systemic issues, things like the ethical use of electronic medical records, global health, and the nurse's duty to the healthcare environment itself.
Because academics in nursing and medical ethics use 5 core terms to define the pillars of this ethical framework.
And while they sound like words we use in everyday life, they operate very differently in a clinical setting.
For example, beneficence. On the surface, that just means, doing good.
Right, but in the ANA code, which references it in 89% of its provisions, by the way.
89%? Wow.
Yeah, beneficence is an active, affirmative duty. You can't just be a passive observer.
You literally must act to prevent harm and benefit the patient.
And that active duty to do good immediately slams into the second pillar, which is non-maleficence or doing no harm.
Which, in modern medicine, doing no harm is almost impossible.
Think about a bone marrow transplant or aggressive chemotherapy.
Right, the provider is causing immense agonizing physical harm to the patient.
Exactly. Non-maleficence in the modern era is about the calculus of balancing that unavoidable harm against the long-term benefits of the good achieved.
It's a brutal calculus.
Yeah.
You literally have to bring a patient to the brink of death to cure their cancer.
And while you're balancing beneficence and non-maleficence for that one patient, you have to look at the entire hospital floor.
Which brings in the third pillar, justice.
Justice, meaning treating others equitably and distributing benefits and burdens fairly.
And we saw how devastating the application of justice can be during the COVID-19 pandemic, didn't we?
Oh, absolutely. Hospitals had to decide how to allocate scarce resources like ventilators and ICU beds.
What is fair when you have 3 suffocating patients and only 1 machine?
You give it to the youngest, the one most likely to survive, the one who arrived first.
It's an impossible choice. Justice is incredibly difficult to codify because fairness is just so subjective.
Exactly. And all of this has to be communicated to the patient through the fourth pillar, fidelity.
Fidelity, which is about loyalty, truth-telling, and keeping promises.
Right. And then there's the fifth pillar, respect for autonomy.
Autonomy acknowledges a person's absolute right to make their own choices based on their personal values.
Which is exactly why informed consent exists. And autonomy is found in 44% of the ANA provisions.
But here's the problem, right? These pillars constantly contradict each other.
They absolutely do, all the time.
You want to do good beneficence by giving a life-saving blood transfusion. But the patient's religious beliefs forbid it, so they refuse.
That's autonomy right there.
So how does a provider decide which pillar wins when the ethical framework is basically at war with itself?
Well, that is where the two major moral theories driving healthcare come into play, and they operate like competing operating systems in a provider's brain.
Okay, let's hear them.
The first is utilitarianism, or the consequentialist approach. This was championed by philosophers Jeremy Bentham and John Stuart Mill.
And it was actually born out of the Industrial Revolution, right?
Yeah, it was a reaction to the massive social injustices and poverty of the working class at the time.
So utilitarianism focuses entirely on the consequences of an action, aiming strictly for the greatest good for the greatest number of people.
Right, so the math dictates the morality.
Like if you are running a triage tent after a massive earthquake, utilitarianism says you bypass the single person with severe catastrophic injuries.
Because saving them would take 10 doctors in 5 hours.
Exactly. Instead, you use those same resources to save 20 people with moderate injuries.
Exactly. It is highly practical for population health, but it has severe flaws if taken to the absolute extreme.
Because it completely strips away the value of the individual.
That brings us to the second theory, the deontological or duty-based approach developed by Immanuel Kant.
Kantian ethics. Okay?
Yeah. It focuses on rational moral duty regardless of the consequences.
Kant argued that humans have a duty to do what reasoning tells them is most rational and universally applicable, right?
Yes, a concept he called the categorical imperative.
Let me make sure I'm wrapping my head around this. Let's say a patient wants to stay in the hospital an extra day just to feel safe before going home.
Okay, common scenario.
Pure beneficence says, yes, let them stay. It makes them feel secure. But Kantian duty to the hospital's scarce resources says, no, it is fundamentally irrational to use a highly specialized acute care bed for someone who does not medically need it.
You have a duty to the system's integrity. What's fascinating here is how Kantian logic limits extreme utilitarianism.
Oh, how so?
Well, if you were strictly utilitarian, you would literally give away all of your hospital's resources to the absolute neediest patients today.
You just empty the pharmacy for the uninsured.
Right. But Kant would argue that is irrational because the hospital would immediately go bankrupt and collapse.
And then you couldn't help anyone tomorrow.
Exactly. Kant forces the provider to ask, if everyone acted this way, would the system survive?
So is this all just like academic? Like, does Kant actually matter on a Tuesday night in the ER?
Oh, absolutely.
Do these philosophical frameworks hold any actual weight in the real world?
They do, and they aren't just philosophical musings for textbooks. These ethical frameworks literally decide court cases, multi-million-dollar payouts, and whether a practitioner keeps their license.
Oh, wow.
The ethical code is actually woven into the legal standard of care.
Which is wild because you assume the law is just what's written in the state statutes.
But the collision of law and ethics in the courtroom is where things get really intense.
Let's look at the Roberto Landon case, because this story completely reframes how powerful these ethical codes are.
It really is a landmark case for understanding this collision.
So Roberto Landon was a nurse in Michigan working at a nursing facility.
He was highly dedicated, had cared for a specific patient for 18 months, so he knew this man's baseline intimately.
And one morning, Landon comes into work and finds out this patient had died during the night.
And Landon doesn't just clock in and accept it. He looks into the chart.
Right. He discovers that the nurse working the night shift had given the patient twice his normal dose of insulin at 9 p.m.
Now, anyone with basic medical knowledge knows insulin drops your blood sugar. A double dose is incredibly dangerous.
But the night nurse didn't check on him for over 4 hours.
When she finally found him on the floor at 1:30 a.m., she didn't check his blood sugar. She didn't call the physician assistant on call. She basically did nothing.
It was gross negligence.
Absolutely. So Landon, acting on the ethical principles of fidelity to the profession and beneficence toward future patients, writes a report to his supervisor calling the night nurse's care incompetent.
He is trying to protect the system. And what happens?
A few weeks later, Landon is fired.
Fired.
Meanwhile, the night nurse who made the fatal error continues to work.
Which is absolutely infuriating. Imagine you're in Landon's shoes. You report a fatal error and you lose your livelihood.
So Landon sues the hospital for wrongful termination in violation of public policy.
But here is the legal trap his lawyers ran into.
Right.
There was no specific Michigan state law that explicitly said a nurse must check on a patient at any specified hourly interval.
Right.
And no specific statute that said a nurse must report a coworker's incompetence.
So the hospital's legal defense was brutal but legally sound. They argued they could fire him because he was an at-will employee making trouble and he had no statutory protection.
Legally, the hospital was on solid ground.
But Landon's attorney did something brilliant. He brought the American Nurses Association Code of Ethics into the courtroom.
He argued that the code established a binding professional duty to report, overriding the lack of a specific legislative statute.
He argued that public policy inherently calls for protecting patients and inquiring into medical mistakes, and the ANA Code is the codified standard of that public policy.
He won.
He won.
The ethical code became a legal weapon to protect the whistleblower. The court essentially said, yes, the state didn't write a law about reporting this, but your profession's ethics demanded, so we are going to enforce the ethics as law.
Exactly. It proved that ethical guidelines aren't just suggestions for being a good person. They establish the legal standard of care.
But we also see this dynamic work in reverse, right?
We do. If an ethical code can protect you, it can also destroy you.
Ethical violations can end a career even if the law you broke had absolutely nothing to do with medicine.
We see this vividly in the Mustafa case in California.
Yes, Mustafa v. Board of Registered Nursing. What exactly happened here?
So, the California Board of Registered Nursing restricted an applicant's nursing license because of 2 misdemeanor convictions for petty theft.
Now, to be clear, these thefts did not happen in a hospital. They didn't steal medication.
Right, they happened in a retail store. But the court ruled in favor of the board's decision to restrict the license, arguing that dishonesty fundamentally violates the core ethic of nursing.
I mean, it makes sense if you think about the vulnerability of the patient.
Oh, completely.
Nurses handle vulnerable people who are often unconscious, heavily medicated, or confused. They have access to their bodies, their wallets, their controlled substances.
If you can't be trusted not to steal a sweater from a department store, how can a patient trust you with their life?
Precisely.
If we connect this to the bigger picture, the Board of Nursing's primary mandate is to protect the public.
They achieve this by marrying legal statutes, like the California Nursing Practice Act, with these deep ethical codes.
But the court also drew a very specific boundary in this case. They ruled the board cannot restrict a license for totally unrelated infractions, like vandalism or speeding.
Wait, why not? A crime is a crime, right?
Well, because a speeding ticket doesn't fundamentally break the ethical pillars of fidelity or beneficence in the way that theft does.
Oh, I see.
Speeding is a lapse in judgment. Theft is a breach of trust. The law recognizes that difference.
Here's where it gets really interesting. We just saw the ethical code act as a legal shield for Roberto Landon, protecting him when he did the right thing.
Yeah.
But if these ethical expectations are so legally binding and they blur so heavily with the law, can they also act as a trap?
What do you mean?
What if someone is just trying to help, but by stepping into their ethical role, they expose themselves to legal ruin?
Yes. That perfectly tees up the classic, terrifying hypothetical every single medical professional faces when they take off their scrubs and step out into the real world.
The grocery store dilemma.
Exactly.
Yeah.
Situation 1 from our sources.
Okay, picture this. Imagine you are a nurse practitioner. You are off the clock, wearing sweatpants, standing in line at the grocery store just trying to buy milk.
Sounds like a normal Tuesday.
Suddenly, a woman in the aisle next to you drops to the floor and starts having a grand mal seizure.
People are screaming for help. Someone yells, is there a doctor or a nurse? What do you do?
As a layman, you just call 911 and hope for the best. But as a medical professional, the pressure must be paralyzing.
It is. Our sources break down 4 distinct forces that are suddenly warring inside this off-duty NP's head in a matter of seconds.
Okay, what are they?
Fear of a malpractice lawsuit, fear of abandonment charges, the need for compensation, and personal ethical values.
Let's address them one by one, because the way the law views this is going to shock a lot of people.
First, the malpractice check. To be successfully sued for medical malpractice, 4 specific legal elements must be present.
What are those elements?
There must be a duty of care owed to the patient, a breach of the standard of care, and injury and causality, meaning the breach directly caused the injury.
And this is the wildest part to me. If the nurse practitioner just walks away, literally turns their back, leaves their groceries, and walks out the sliding doors, there is no duty of care established.
That's right.
You cannot be sued for malpractice if you never engage with the patient.
It sounds incredibly cold, but legally, it is entirely true.
It's crazy.
There is no legal requirement in most jurisdictions for a healthcare provider to treat a stranger on the street. By engaging, by stepping forward and saying, I'm a nurse, you establish the duty of care.
And the second you establish that duty, you open yourself up to the liability of the other 3 elements. If you make a mistake while trying to help, you can be sued.
Exactly.
Okay, but what about patient abandonment? If you walk away while someone is seizing, couldn't the nursing board strip your license for abandonment?
Actually, no. The abandonment check reveals that patient abandonment only applies if a nurse-patient relationship was already accepted and established and then severed without reasonable notice.
Oh, wow.
Yeah, walking by a stranger in aisle 4 does not constitute abandonment because the professional relationship never existed.
And just to cover all bases, the reimbursement check. Obviously, there are no billing codes for aisle 4 of the grocery store.
Right. You aren't getting paid to take on this massive legal risk.
Which leaves only the 4th force, personal ethical values. The pillar of beneficence is screaming at the provider to help.
But the NP has to do a rapid Kantian analysis. Do they even have the legal authority to diagnose on the street without a collaborating physician, depending on their state laws?
And do they even have the right tools?
Exactly. The standard medical treatment for a prolonged grand mal seizure is intravenous Valium. No one carries IV Valium in their grocery cart.
So even if you step in, all you can really do is clear the area and protect their head from hitting the tile, which, frankly, any random bystander can do.
You can't perform medicine without tools.
Exactly. Sometimes jumping in when you don't have the tools or the controlled environment does more legal harm to you than medical good for the patient.
It's a very harsh reality.
It's like being an off-duty lifeguard. If you jump in the ocean to save someone, you own the rescue and you own the liability if they drown while you're pulling them in.
That's a great analogy.
If you stay on the sand, you're legally completely safe, but you have to live with yourself. You have to walk past someone in distress.
It is a profound moral burden. It pits your humanity against your legal survival. But let's transition from the street back into the clinic.
Because if avoiding intervention keeps you legally safe in the grocery store, what happens when you are actively treating your own patient and your intense ethical desire to help them actually crosses the line into a federal crime?
Right, because the ethical traps don't end when you put the scrubs back on. This brings us to the money trap. Kickbacks, fraud, and what the text calls the Robin Hood scenario.
The Robin Hood fraud is one of the most common, insidious ethical traps that well-meaning providers fall into.
Situation 4 in the Buppert text outlines this perfectly. Imagine you have a patient who desperately wants to quit smoking. Their health insurance will pay for a drug called Wellbutrin, but only if it's prescribed to treat depression. The insurance categorically denies coverage for a drug called Zyban, which is specifically marketed for smoking cessation.
But here is the kicker, and the reason providers get so incredibly frustrated. Wellbutrin and Zyban are the exact same drug.
They are. The chemical is bupropion.
It's the same medication, the same dosing. The only difference is the label on the bottle and the insurance company's completely arbitrary rules.
So as the provider, you want to help the patient quit smoking to save their life. You want to save them hundreds of dollars a month out of pocket.
You just write down depression on their medical chart so the insurance covers it?
If you do, you have just committed federal healthcare fraud.
Wow.
Under 18 U.S.C. Section 1347, executing a scheme to defraud a healthcare benefit program is a federal crime. You can face up to 10 years in federal prison.
10 years?
Yes. And if your fraud somehow results in serious bodily injury, it's up to 20 years. If it results in death, you can face life in prison.
All for trying to get a guy the exact same chemical to help him quit smoking.
And the source points out the severe unintended consequences of this Robin Hood Act, too.
Right. Let's say you fake the depression diagnosis. 5 years later, that patient applies for a job that requires a rigorous medical background check.
Maybe he wants to be a commercial airline pilot.
Or join the military. Or get a high-level security clearance. Suddenly, his official medical record says he has a history of clinical depression.
You have just destroyed his career prospects because you were trying to play Robin Hood with his insurance.
This raises an important question about where the provider's allegiance truly lies when the system is broken. In this scenario, the provider's beneficence, wanting the patient to afford the life-saving drug directly, violently conflicts with fidelity truth-telling and maintaining accurate records for the insurer.
The law demands fidelity to the insurer over beneficence to the patient's wallet.
And it isn't just about saving patients money, It's about the money flowing to the providers themselves.
Ah, yes. The temptation doesn't just come from wanting to help patients. It comes from massive corporations wanting to influence providers.
Let's talk about Big Pharma.
The source gives a scenario where a pharmaceutical company offers a nurse practitioner $500 and a gourmet dinner to attend a roundtable discussion on new cholesterol medications.
I mean, it sounds like an easy $500 and a nice steak.
It does. But both the pharmaceutical industry and the federal government have extremely strict guidelines to prevent kickbacks.
The FHRMA code and the Office of the Inspector General guidelines are incredibly rigid today.
In the past, drug reps would take doctors to golf tournaments. Now, the FHRMA code actually prohibits the distribution of any non-educational items whatsoever.
You can't even accept a pen with a drug logo on it anymore.
Or a sticky notepad. Because data consistently shows that even small subconscious tokens influence prescribing behavior.
No pens. It sounds absurd, but it makes sense if it's swaying how a doctor treats a patient. But what about the $500 for the round table? Is that legal?
It depends entirely on whether it fits into the safe harbor regulations from anti-kickback laws.
Okay, think of a safe harbor like an incredibly strict prenuptial agreement in a marriage. Everything has to be documented, timed, and valued in advance so that no one can claim they were bribed after the fact.
To be legal, it requires a written contract of over 1 year. The aggregate compensation must be set in advance at fair market value, and the provider actually has to be providing a legitimate, necessary consulting service.
They can't just be sitting passively eating a steak while a drug rep gives a sales pitch.
Right, because if you're just getting paid to be marketed to, the government views that as a kickback to incentivize you to prescribe their expensive drug.
And the government does not play around with this. The primary weapon they use is the False Claims Act.
What's fascinating here is the history behind that. President Abraham Lincoln actually originated the False Claims Act back in 1863.
Wait, really? Lincoln?
Yeah, he created it to stop corrupt contractors who were defrauding the Union Army during the Civil War by selling them sick horses and faulty rifles.
That is wild. And today, it is used to combat healthcare fraud. And modern whistleblowers are financially rewarded with a percentage of the recovered funds for reporting multi-million-dollar fake billings.
Like the textbook exercise where a clinic owner billed $1.28 million in fake occupational therapy services using provider numbers without their consent.
That is straight-up theft from Medicare.
Yes. And because the government is cracking down so hard, hospitals now employ utilization review nurses.
These are highly trained nurses whose entire job is to essentially audit their own doctors and nurses, right?
Exactly. They do rigorous pre-billing checks to catch fraud and verify that the medical documentation absolutely supports the diagnostic coding before the government ever sees the bill.
So what does this all mean? We have providers facing federal prison for helping a smoker afford medication. We have anti-kickback laws regulating ballpoint pens. And we have utilization nurses policing the doctors to prevent Lincoln's False Claims Act from triggering.
It's a lot.
When a provider is constantly forced to choose between the patient's well-being and the rigid, punitive rules of the financial system, it breaks them down psychologically.
It really does. Which brings us to a hidden, devastating epidemic in healthcare. We need to talk about paternalism, therapeutic fibbing, and moral distress.
I want to start with therapeutic fibbing because the very phrase sounds like an oxymoron. Lying to heal.
The text gives a haunting example of a patient with severe dementia living in a memory care facility.
She constantly asks the nurses when her husband is coming to visit.
Mm.
But her husband has been dead for 5 years.
This is a devastating everyday reality in nursing. If a nurse strictly follows the ethical norm of veracity, which is truth-telling, they are obligated to look at this woman and tell her that her husband has passed away.
But think about what happens if you do that. Because of her dementia, she doesn't remember he died.
So she experiences the raw, agonizing, earth-shattering grief of losing her husband for the very first time. She weeps, she panics.
And then, because her short-term memory is gone, she will forget the conversation in an hour.
She'll ask where her husband is again and have to relive that horrific grief on an endless loop multiple times a day.
It's psychological torture. So in this specific scenario, non-maleficence, the duty to do no harm, overrides veracity.
Right. The nurses engage in therapeutic fibbing, and they look at her and say, he's at work right now, he'll be here soon, or he called and said he loves you, but he's running late.
It prevents the cyclical grief and keeps the patient calm. But it requires the nurse to intentionally lie, repeatedly, to a highly vulnerable person.
Which brings us to paternalism.
Now, paternalism sounds like a dirty word in modern society, like a parent talking down to a child, or the patriarchy making decisions for you without your consent. It feels like a violation of autonomy.
But in memory care, or in cases of severe incapacitation, it's actually an act of deep, necessary empathy.
It is. Paternalism is often viewed negatively because it inherently overrides a patient's autonomy. But it is absolutely essential when a patient is incapacitated.
The sources cite bioethicists Al-Bar and Chomsky Pasha, who define 5 strict criteria that must be met for paternalism to be ethical.
Okay, let's hear them.
Instead of just listing them, think about a patient suffering from severe schizophrenia who is refusing a life-saving blood transfusion because they believe the blood is poisoned by aliens.
Okay, so first, the patient must be at risk of significant preventable harm, in this case, bleeding to death.
Second, the paternalistic action forcing the transfusion will likely prevent the harm.
Third, the projected benefits heavily outweigh the risks.
Fourth, there is no reasonable alternative. And fifth, it must be the least restrictive alternative possible.
So you aren't just making arrogant decisions for people because you think you know better than they do. You are legally and ethically stepping in to protect someone who literally cannot protect themselves.
But taking on that burden lying to the dementia patient, overriding the schizophrenic patient's wishes, doing this day in and day out takes a massive psychological toll.
A catastrophic toll.
Yeah.
And it leads directly to what is known as moral distress.
Moral distress is a very specific psychological phenomenon. It occurs when a professional knows the right ethical thing to do, but systemic constraints like hospital policy, insurance rules, or lack of resources make it impossible to execute that action.
And the sources heavily highlight the impact of the COVID-19 pandemic on this, don't they?
The pandemic was essentially a mass casualty event for healthcare provider psychology. Nurses faced unpredictable, overwhelming caseloads.
But the moral distress came from the pharmacies.
Exactly. They had to enforce strict isolation protocols, which meant they were the only ones in the room when patients died because families were completely shut out of the hospitals.
They had to ration scarce resources. A nurse knew the ethical thing was to let a wife hold her dying husband's hand in his final moments.
But the systemic constraint of the virus and hospital policy made it impossible. They had to hold the iPad while the wife cried on FaceTime.
The symptoms of that kind of moral distress aren't just feeling sad or needing a vacation. The text outlines severe physical and psychological symptoms.
Deep frustration, loss of self-worth, depersonalization of patients, where the patient just becomes a task rather than a human.
Heart palpitations, insomnia, severe GI issues, People were fundamentally breaking down.
To mitigate this, experts recommend specific practices that hospitals need to implement.
Like what?
Establishing medical pauses after a patient passes to collectively honor their life before rushing to clean the bed, conducting team debriefings, instituting gratitude practices, and actively cultivating moral resilience.
And what's fascinating here is that the ANA Code of Ethics actually requires this self-care.
Wait, really? It's not just a suggestion from HR. It's legally and ethically required to take care of yourself.
Yes. Provision 5 of the ANA Code explicitly states that the nurse owes the same duties to self as to others.
That is incredible.
That includes preserving wholeness of character and maintaining personal and professional competence. If a provider works themselves to the bone and burns out to the point of depersonalization, they are actually failing their ethical duty to the profession. You cannot pour from an empty cup.
Wow. You have a codified ethical duty to not let the system destroy you. But that puts the burden back on the individual.
Yeah.
How do we fix a system that causes so much moral distress in the first place? How do we change the labyrinth so the Minotaur isn't constantly eating the nurses?
That leads us to our final exploration. System hackers, scope of practice, and national policy.
If you want to change the system, you can't just focus on the bedside. You have to look at the rule makers. And in healthcare, one of the biggest, most vicious battlegrounds is scope of practice.
Scope of practice is basically a legal turf war. It dictates exactly what a medical professional is legally allowed to do.
And it's not just about who can physically do the job safely, but who is legally allowed to bill for the job.
Precisely. It is about money and control. Without clear scope of practice laws, nurse practitioners can actually be criminally charged with practicing medicine without a license, even if they are performing procedures they were thoroughly trained to do in grad school.
The landmark case here is CERM Chief v. Gonzalez from 1984. Two highly trained obstetric-gynecologic nurse practitioners in Missouri were working in a family planning clinic, providing routine care.
The State Board of Medicine, composed of physicians, charged them with practicing medicine without a license.
A board of doctors trying to shut down specialized nurses because they viewed them as competition.
Yes. The lower court agreed with the doctors and threatened the nurses with criminal charges. But the case went all the way to the state Supreme Court, which overruled the lower court.
Oh, wow.
The Supreme Court noted that the state legislature had recently intentionally rewritten the Nursing Practice Act to remove the rigid physician supervision requirements, recognizing that nursing had evolved into an advanced profession.
It was a massive, historic win for nursing autonomy.
And we are still seeing these intense battles today. Look at California's Assembly Bill 890, which passed in 2020.
This was a massive legislative shift. It finally allows nurse practitioners in California to practice independently without strict physician supervision after completing 400 through 600 hours of clinical experience.
And if we connect this to the bigger picture, we have to ask why California finally passed this in 2020 after years of the powerful medical lobby successfully blocking it.
The answer is COVID-19. The pandemic completely exposed the severe, catastrophic primary care shortage in the state.
The system literally could not function without giving advanced practice nurses more autonomy. The legislature's hand was forced by reality.
And when you give advanced nurses the power to change systems, they actually do. The Waxman text highlights doctors of nursing practice, or DMPs.
These are nurses who have reached the absolute highest level of clinical education, right?
Yeah, and they act essentially as system hackers. They look at a broken, inefficient process on the hospital floor, and they fix it.
The examples in the text are incredibly inspiring.
Tell me about them.
Well, Dr. Rosalie Geronimo noticed inefficiencies in how patients with pacemakers were cleared for MRI scans. She implemented new MRI pacemaker protocols that dramatically enhanced patient safety and eventually resulted in a $200,000 net gain for her facility by streamlining the process.
That's amazing.
Then you have Dr. Emily Trefethen, who created an interprofessional training program that drove expensive heart failure readmissions down by 12%.
And Dr. Melinda Furr tackled the moral distress we just talked about head-on. She trained new nursing graduates in moral courage, which directly combated a 27.7% turnover rate among new nurses.
These DMPs are translating academic research into actual localized policy that saves money and lives.
But how does their localized success force changes at the macro level? Because ultimately, we have to talk about national healthcare policy.
If DMP hackers are proving that care can be delivered more efficiently, it forces state and federal lawmakers to reevaluate the national market mechanics.
It forces the question, is healthcare a fundamental human right, or is it a market privilege?
That is the philosophical debate, at the very heart of American politics. Interestingly, the source notes the historical irony that Eleanor Roosevelt actually helped draft the United Nations Universal Declaration of Human Rights back in the 1940s.
Which explicitly included healthcare as a fundamental human right for all people.
And yet, the United States remains one of the only industrialized nations with a predominantly market-driven healthcare system.
Which brings us to the alphabet soup of recent American healthcare legislation. First, the ACA, or the Patient Protection and Affordable Care Act of 2010.
The mechanical goal of the ACA was to expand coverage through Medicaid expansion and the creation of insurance marketplaces, while legally mandating coverage for pre-existing conditions.
It utilized market mechanics subsidies and individual mandates to drive up the insured population.
But the mechanics of the ACA faced fierce opposition regarding federal overreach and the economic burden on small businesses and states.
So in 2017, the American Health Care Act, or AHCA, was introduced in Congress as a repeal and replace measure.
The AHCA's mechanics aimed to cancel the individual mandate penalties, repeal the new taxes on healthcare providers, and reduce federal Medicaid funding by an estimated $880 billion over 10 years, shifting that financial management burden back to the individual states.
However, it was pulled before a final vote could be taken.
But the legal battles over the mechanics of national health care didn't stop in Congress. In 2021, the Supreme Court ruled on California v. Texas.
Right, a massive case attempting to strike down the ACA entirely based on the argument that the individual mandate was unconstitutional once the tax penalty was reduced to zero.
And this is where legal strategy gets fascinating. The Supreme Court ultimately preserved the ACA, but they didn't do it by making a grand philosophical ruling about human rights or the morality of healthcare.
They did it on purely procedural grounds. They voted 7-2 that the plaintiffs, the states trying to strike down the law, lacked standing.
Standing. That's a term we hear a lot but rarely understand. What does it actually mean in this context?
Standing is a foundational legal principle. It means that to sue someone or challenge a law, you must prove that you have suffered a concrete, direct, and personal injury because of that law.
Oh, I see.
The Supreme Court ruled that because the penalty for not having insurance had been reduced to $0, the plaintiffs couldn't prove they were being financially injured by the mandate.
No injury means no standing. No standing means the court dismisses the case without ever ruling on the actual philosophy of the law.
So the entire national healthcare infrastructure, which impacts millions of lives, survived on a legal technicality about who has the right to sue.
It is also incredibly precarious. And hanging over all of this policy, all of these ethical debates, is the constant looming threat of malpractice.
The financial realities of malpractice are staggering, and they dictate hospital policy just as much as federal law does.
According to the NSO report cited in the text, the average cost of a nursing malpractice claim is over $210,000.
In high-risk fields like obstetrics, the average claim skyrockets to $558,000.
And nearly 41% of all malpractice deaths result from cardiopulmonary arrest, which is why response protocols are so rigidly enforced.
So let's synthesize all of this.
National policy and the Supreme Court dictate who gets insurance. Scope of practice laws dictate who is legally allowed to treat those patients.
Financial realities and the terrifying threat of malpractice payouts dictate how the hospital's legal department allows you to operate.
And at the very bottom of this massive crushing pyramid is the individual nurse, physician, or provider standing in a patient's room trying to apply their ethical framework of beneficence and non-maleficence while trying not to trigger Lincoln's False Claims Act and go to federal prison.
It is an incredible, exhausting tightrope. They are balancing Kantian duties to society against the Robin Hood urge to save a patient money.
They are navigating the agonizing emotional terrain of therapeutic fibbing with dementia patients.
And they are constantly watching their backs in a politically volatile, highly litigious system where a single mistake can end their livelihood.
It makes you wonder how anyone has the resilience to do it day after day. We've talked entirely about human ethics today. The immense burden on the human heart and the human license.
It's a lot to carry.
But here is a final provocative thought to leave you with, something that builds perfectly on everything we've discussed today. As hospitals rapidly integrate artificial intelligence to diagnose patients, allocate resources, and approve or deny insurance claims, who holds the ethical compass then?
That is the question.
If an AI algorithm denies a life-saving treatment based on cold utilitarian math, because it determines the patient is statistically unlikely to survive, who gets sued for malpractice, who feels the moral distress, When the decision maker is a machine, where does the A&A Code of Ethics fit in?
That is a whole new labyrinth for another day.
Thank you for joining us on this deep dive.